Great. What an incredible group of panelists who just spoke. I'm so inspired by all of your stories. Thank you so much for sharing. That was great to hear from the young and upcoming folks in global oncology. And so now we're going to sort of turn this around and hear from our more senior mentors and chairs. And it's great to sort of see a lot of the people who were on the panel have either chairs or supporters of people who they've worked with who are on the next panel. So it'll be a great dichotomy to sort of understand how our senior mentors support young folks who are interested in global oncology. So I would like to invite our senior panelists up. So we're going to have 6 people who are speaking today. 5 of them are here, and 1 will be joining us online. And similarly to how the last session was conducted, I will briefly tell you a little bit about them. They're an incredibly accomplished group of people. I'll briefly tell you about them, and we've asked each of them to sort of make a slide just answering a couple of questions about global oncology, and I'll show you those questions in a little bit. And then we'll sort of open it up to the rest of the group for discussion. So as part of our 6 panelists, we have Dr. Shad, who is a professor of pediatric oncology at Georgetown University. And she has done an amazing amount of work and is actively involved in developing pediatric oncology programs in developing continents, particularly in Asia, in the Middle East, and Africa. So Dr. Shad, if you could come up. We also have Dr. Wong, who's a professor of radiation oncology at Princess Margaret Cancer Center at the University of Toronto. She also serves as the director of education at the Princess Margaret Department of Radiation Oncology, and she has focused a lot on building capacity, global capacity through education and training, as well as runs lots of clinical trials in GI malignancies. Dr. Wong? Dr. Metz is a professor and the chair of radiation oncology at the University of Pennsylvania, the Perelman Center for Advanced Medicine. He's also the associate director of the clinical services at the Abrahamson Cancer Center in Pennsylvania, and he's also the executive director of a company called Oncology. That's an online tool that provides access to improved cancer-related information to patients, families, and health professionals. Dr. Metz? Dr. Gopal, I think, is going to be joining us online. But he is a medical oncologist and an associate professor of medicine at the University of North Carolina, and also serves as an associate professor of epidemiology at UNC's Global Public Health. His goal is to work on developing innovative resources to appropriately prevent, diagnose, treat, and palliate cancer. And he spends a lot of his time in Malawi. Dr. Gopal, hopefully online somewhere. Dr. Formenti is a professor and chair of radiation oncology at the Weill Cornell Medical College and serves as the associate director of the Meyer Cancer Center there. Dr. Formenti is trained as a medical and radiation oncologist and has worked on translating novel preclinical information and bringing that into our clinic. And notably, Dr. Formenti was instrumental in identifying the relationship between radiation and immunotherapy and really defining the abscopal effect of radiation. So Dr. Formenti. And last but not least, Dr. Cleary is a professor of medicine and medical oncology and currently serves as the senior chair and director of the supportive oncology at the University of Indiana. Prior to going to Indiana, Dr. Cleary served as the medical director of palliative care at the University of Wisconsin, and he's been really instrumental in developing hospice and palliative care guidelines for the WHO, as well as for ASCO's chair on developing guidelines for low resource settings. Dr. Cleary.
Thank you.
As I mentioned, we have an incredibly accomplished group of individuals up here, and what we sort of want to do is get their perspectives on what a global oncology career looks like and how do they support these young people who are interested in global oncology. We've asked each of them to answer 3 questions. And as the presentations come up, you'll see what those questions are. So the first question really is, why is global oncology important? So you heard stories from our young investigators on why they do this, what their drive is. And so we want to hear from our senior mentors, why is this important? And we want them to be able to address key factors in supporting and or doing global oncology work. We've also asked them to discuss how they advise faculty, residents, and students who are interested in global oncology. And ask them to address what they're interested in when people come to them saying, I want to do global health work. And then we've asked them to sort of discuss how they balance their department's clinical interests and supporting the faculty professional development of their junior faculty. So we'll start with Dr. Formenti.
Thank you very much, and I have to say I'm humbled because the previous panel shows so much more real, concrete accomplishment that much of what I've done all my life that, is a little weird to be a mentor. So maybe I can use a little bit of my experience, but there is so much to learn from the mentors. Anyway, so these are the questions that I'm going just to briefly, and I'll expand a bit more, but how do you balance department clinical interest and supporting your junior faculty professional development is an exercise of creativity, because particularly for this global health pathway, there are still barriers, and I'll try to talk about it in a minute. Of course, it is a central mission of the department. And, it was another question that I thought was pretty tantalizing. Should the faculty member that being considered for academic or private practice positions express their interest in pursuing global oncology missions in the interview trail? And does it hurt their chance of employment? And I think it really depends on the interviewer. Will be dishonest to say, of course, rave poetic about your global health interest. But, I would suggest that if you look for a job, do not interview in a place where there is not yet a global health interest. Not so much because, of course, we want to spread it at all programs in the country, but we're asking you a lot to try to modify departments where the interest is not there. And I'm not so sure the burden should be on the most junior faculty looking for a job. So, try to reconcile it, but realistically, I'm not so sure you should burn your energies to convert departments that have no interest in global health to acquire that interest. This is more our job at a different level. And so the appropriate time, I really don't know. I'm learning, and I don't think you can really fix it, but I tend to suspect that you really need a trimester a year to give mobility, to give enough mobility to junior faculty who's growing into that. And certainly I will try to work in that direction, and maybe some years, an entire year, so it really requires a lot of flexibility. And so should global oncology endeavor outside the department be pursued on each individual time, or can individual have CME time dedicated to it? I think that the time has to be protected. It's very clear to me. It's like the way you protect time for the lab, the way you protect time for clinical investigations is physics, research is the same. Can you see this path toward academic promotion? Absolutely, and a lot of work going in that direction. What should the role of the external grants play in supporting faculty salaries or time away from clinical duties? It is central. It's not the money itself. Is that at least in my opinion, the way to convince the country that this is really a serious academic pathway is by playing a little bit in the game. So they need to have grants and publication. For us to change the metrics is not going to be that easy. Even small grants, but show that they competitively acquire the grants, because that's the language we speak with in academia. So I'm going to briefly, more than barriers to mentors, I'm going to talk about opportunities and a little bit of our experience, the alliances, and now we somehow try to do a little bit of research, and not me, but only intervention, and at least we try to support those interventions. And then if I can leave you with one message, is listening to our mentees, because many of the chairs in this country really don't have a background on this field. I don't. I have a lot of good intentions and interest, but this is going to be a reciprocal learning. So there is a lot that we have to learn from. So we heard, like, to 2020, incredible burden of cancer, 20 million new cancers, 70% in developing countries. So the WHO has recognized it, everybody's alert, and that's my vision of where academia is. Not that there's such a giant in terms of economical weight, but it is a giant as an influencer, and people work so hard to get their kids into the Ivy League, and we all try to excel, and it's such a important component of American culture, academia, and I don't think they are working much in this direction. If you think they could, if we had like a rule that they give 1% of their budget to a global health, that will already make a difference. So as much as it's very easy to ask NIH, ask different sources, American Cancer Society, but is academia really paying a little bit of dues to the global health, particularly medicine? It's not only medicine, but particularly medicine. So I think that's a first, and we could add, the press, it could get much more attention to make academia a little bit more responsible. So we're lucky at Cornell. I'm personally quite lucky. I got an angel to join the department, Dr. Brereton, who is coming for free, and is dedicating enormous amount of his time, attention, energy, experience to all of us, and particularly to this project. And he's a much better mentor than me to Oni and others who are interested in this field. And I also, by complete chance, got a dean who is a foreigner, who is a son of a physician from South Korea, who very young, with a young family, moved to Malaysia and worked as a general practitioner. His father in a village in Malaysia, and he grew up on the edge of the forest, and was South Korean in a country was not his country, and had to learn the language, and eventually, a fantastic career. Managed to become professor at Pittsburgh, and eventually in charge of pulmonary medicine at Harvard, and then a head chair of medicine at Cornell, and dean now at Cornell. So he's somebody who gets it, who understands the burden of disease in developing countries, who cares, and who cares about diversity. He profoundly cares about diversity and disparities in healthcare. So, I couldn't be more fortunate. Oni couldn't be more. When I recruited Oni, she was my senior resident at Cornell. I was moved to Cornell. There was a different dean, a fantastic person, but certainly not with this priority. So Oni took a big risk, and I didn't know whether I could protect her career in this field. And we've been super fortunate with him, to a point that he's really a partner. He's really listening. So, and after all, one thing I've learned after all these years in medicine and in administration and academia is you get a sense when people are listening or when they're not. He is listening. So one little piece of research, because I was super fortunate, and I throw around a lot of ideas, and rarely I follow through because I'm pulled in all directions. And when I was at NYU, I got a brilliant couple of residents, but Ray Mayo Vega, who is now a faculty with Nancy Mendenhall at University of Florida, he immediately thought, this is fantastic. I started asking myself, what's going on when we lose all these human lives, all these young women to breast cancer and to cervical cancer, and in general to cancer in developing countries where they seem to die earlier of cancer than in richer countries. What happens to their kids? And I had read I come across an article about HIV and the impact on mortality, mommy's mortality, what happens to the kids and so on, and then I had some experience and some interaction with Tanzania, Mwanza, where there is an orphanage, and I had learned that, it's pretty horrible. 1 minute, sure. Pretty horrible for kids in developing countries to lose their mom, and certainly is complicated because it's really bad in terms of having an impact on their mortality. But for the survivor kids, is even more dangerous because in many of these countries there are no orphanages. So I thought maybe if we put together a little bit of modeling and and Ray did all the work, we can get the attention. And we got enough attention. It's a very read journal, so that went in publication. So it was a beginning. And then, of course, much of my work has been minimal in trying to enable the coverage versus the, in very external support to Oni, who did all the work from Armenia to Gabon, and you have heard about her work, and, I'm not going to try to represent it for her. So it's extremely peripheral to her effort. So, but, just because of Oni and her energy and with the help of Armour, we got the dean interested in this pathway. And I think this is the least we can do in academia for the people who represent academia today, is to try to converge into a very stable, very robust set of rules and for a pathway, for a career in global oncology. So a classic promotion pathway with the same we have it for basic science, translational science, or clinical investigation. It has to become super solid. And of course, with the metric standards have to be developed and so on. So the last thing I want to say is that I first authored this was a very conflictual production because the other chairs were much less convinced than me that the message of this next physician scientist should, the really main take-home messages was also to learn from them. And I think I couldn't stress it enough for this field. So you guys are going to go out to do this research, and we as chair have to learn from it.
Thank you so much. Sorry.
I'm done. So I just want to thank the people who really started all of this that remain my favorite perennials. So I'll stop there.
Thank you, Dr. Formenti. She sort of touched on a lot of the things we would want to discuss as a panel, so I think we'll just move right along ahead. And then I will ask that people keep their talks to about 4 minutes so that we can get more panel discussions. Let's see, whose slides do we have next? Should we do Dr. Cleary?
Yeah, so I don't have slides. So good. But I wondered if we can actually have that up there. I'm a palliative care physician trained as a medical oncologist in Australia. The theme of this conference is partnering to transform global cancer care. We've heard a lot about interventions, therapies, chemotherapy, surgery. What I do is care. We never withdraw care. We may withdraw interventions, but care is what we're really all about here in cancer. And that's why I think it's so important. It would surprise you that 80% of the world's population lack access to morphine. So when we talk about having this surgery, you don't get access to pain relief after surgery. No treatment for mucositis available for radiotherapy. Chemotherapy, no antiemetics available as we go through this, looking at the generalized care. So this is absolutely critical. As much as in the United States we now hear that palliative care is going upstream and it's not just about the dying. It is about the dying as well. It's not just about the dying. And we've heard from speaker after speaker the number of people who actually die from cancer in low and middle income countries. We have to provide care for these people. So I got into this. I was trained by a Ugandan oncologist, Charles Awani in Australia, who introduced me to Paul Carbone. Paul Carbone actually worked at the NCI in Uganda. He actually established through ASCO the Cancer Network and Research of Taiwan, which has gone from literally a middle-income country, somewhat even low, to a high-income country with a great cancer network and the research they're doing in Taiwan. And how did Paul actually do that? He brought over international or US experts who each spent a month of a year training people in Taiwan, the importance of training in those countries. So critical to this is relationships. And I think if we're going to do this and if you're going to follow careers, follow relationships. And that's what I've learnt most. Now, you can't always be guaranteed. I've just moved to Indiana, and one of the first questions I asked with Dr. Lair when I was interviewing is, how long are you going to be here, Pat? How many more grant cycles are you going to actually be here for? So while you've got to build on those relationships, you've got to get into places and actually develop the relationships. The other thing that I was going to comment on is that there are other ways. I've run a WHO collaborating centre for a number of years, so working with collaborating the WHO is critical. Spend some time actually getting off to the UN meetings. So I've been for the last 10 years going to the Commission on Narcotic Drugs in Vienna and the World Health Assembly in Geneva. I spend a lot of time sitting in the Serpentine coffee shop in the WHO or in the UN in Geneva. It's about relationships and meeting those people. So I have great connections through the NCI, through the US government, in ways that people back home or back in the universities aren't actually aware of. I think we really need relationships are critical. The other sort of funny thing was I was going to travel with a single airline alliance. And you sit there and say, really? You can actually cope much better if you actually start getting some of the privileges that go with this. If you get into a lounge, you can actually get some work done. It becomes critical. In terms of impact, and I've been on the receiving end of this, how do you justify your time away? If I'm in Europe, I actually do a day at meetings and then go back to my hotel and do a day of work for the US. And this was critical so that I would attend meetings. I chaired our scientific review committee for the Cancer Centre for a number of years. You've got to be participating back home, I found, and it's available with the internet. You can do this stuff, participate. Plan ahead. Don't create challenges that you're cancelling clinics with 2 weeks' notice. Chairs hate that. So if your notice is you've got to give 8 weeks before you travel, do that and be the leader of it. You don't want your collaborators in clinic, the nurses, the managers complaining, Cleary never gives us enough notice. No, in actual fact, Cleary gave the most notice, he was best prepared, and he actually made sure that everyone who was on chronic opioids had an opioid prescription before he left the country, because the clinic wasn't burdened by my absences. So I think that's actually a very, very critical fact. And if you can do that, you're not raising the alarm bells and saying, you know, you spend too much time away. We calculated that even though I travelled further and did more miles, I was actually gone less days than most of the faculty who work just in the United States. So I'll stop there and engage in discussion. Thank you.
Perfect. Thanks, Dr. Leary. So we heard a lot about building relationships, traveling in style.
Not necessarily, still coach.
But being creative and keeping those relationships and making sure that you're balancing your responsibilities at home as well as your responsibilities outside. Perfect, thanks. Can we go into the next slide?
So I guess I'm up on this one. So, these are some talking points because I just want to hit the same things that others have said before me. But first I want to say I was just so impressed with the panel before us. You're really the future of all this. And I wouldn't be on the other end of you asking something because you're so tenacious. I know you never hear no. You don't even hear it and just go forward. It's amazing what you're able to do. And I want to thank Surbi. She has just been an amazing partner of what she's been able to do in Botswana. We've worked very closely together over the last few years. And also Steve Hahn, who really worked with Surbi to first start this, and it was my job to continue this and figure this out how we pay for it going forward. I want to talk to you just for a minute about just the perspective of a chair when somebody's come in for global oncology looking for resources, and how do you think about that? You know, as a chair, You're the steward of the resources of your department, of your institution. You have to manage your clinical mission, your research mission, your educational mission. And you need to make sure everyone's put in the proper position in regards to their careers, whether they're faculty, students, and the whole mix. And you have to balance that and be transparent in how you do that. And that can be a challenge to balance all of those things, but it's really important to take it that way. When Surbi and I went through this, we thought about how does she establish a career, but also how does she get to a point after the department invests in her? How is she in a position that she can get grants, philanthropic funding, foundation funding, other things to make this sustainable long term? Because you never know when things are going to change economically in the US. And I can guarantee you the first thing that's going to get cut are things going outside the country. So you need to really think about this ahead of time, and particularly when times are good. So Surbi has worked incredibly hard to do that and has made that successful. You also, as a chair, have to think differently in regards to how do you define the ROI? How do you define the return on investment? And if you just go by numbers, it's not going to work. But you need to look at other things. You need to look at how is it contributing to your education. We already heard Melody brought up about things with the next generation of residents coming in for interviews who you want to bring into your institution. They want to see global health programs. They want to see you're really doing it. So it's actually enhanced our programs by having this. It's enhanced opportunities for us to get grants from companies that are trying to build things to put in the global environment. So we've got numerous grants outside of what Surbi does because of what Surbi does. So these all factor into my ROI. And we've learned opportunities for doing education remotely, through the internet, other ways that we've now packaged into programs for vendors. They sell and we get revenue back to support these programs. So you have to think creatively, you have to think differently, and not the same way as the ROI. And one other thing that I thought was important on the educational side, we have crazy technology at the University of Pennsylvania. We've invested so heavily in protons and other stuff, but so few people really have access to that, and it's not the real world. And I want to make sure our residents, our students, understand what the real world is seeing and how to work in the real world. Because those decisions you make with the technologies available in front of you are really important to apply to this high technology stuff. And if you just base all your career on this high technology, you're not going to be a good global citizen. You're not going to understand what the world really needs. And you're not going to be a real well-rounded person, which is a real important aspect for me when I look at the department. So thank you.
Well done.
Perfect. That's interesting to hear from your perspective. You have to be creative about how you work, figure out what it is, not just necessarily money for the department, but how else the global work benefits the entire institution. This is great. Dr. Wong's next.
So thank you for the opportunity to discuss this. I'm the vice chair for our department, and I'm fortunate to come from a long line of leaders within our department, from Bernard Cummings, Mary Gospodarowicz, Fifi Liu, who set the stage and set the tone for the department. I think we can think about this both in terms of policy development led by Mary, and I think Danielle is following her path. But a lot of the other engagements in our department is an evolution and focus around education. I was asked to comment on 3 questions. Why is global oncology important? And I think at the highest level, it fits with the vision and mission for our department, as well as the members within the department individually as to what they want out of their career. I pasted some of the statements that come about after many focus group deliberations. Our current department vision is being global leadership in radiation oncology by transforming practice through innovation and excellence in research and education. Global leadership implies collaboration with others and make a significant contribution. And we want to prepare future radiation medicine leaders using these strategies. Within the university, within the hospital department, our tagline is precision radiation medicine, personalized care, global impact. The word impact is really important, and I learned very early on in my promotion cycle, collecting a lot of titles, even publications, et cetera, is secondary, but really making a change, having an impact on our practice in the future of medicine, radiation medicine, is really what matters to us individually, to the university, and to our careers. The last panel here I like because it's an older statement, and it talks about the obligation to innovate. And obligation here talks about our social responsibility as a caring physician. That's why we all went into the profession and want to make an impact. So together, trying to achieve global meaning, having an impact, and be motivated by obligation, I think it's why global oncology is really important for those who want to be out there physically doing it, as well as for the whole of the department. This is why we exist, and this is why it's important. What are you looking for from a faculty interested in global health work? Passion, I think, goes for everything that we do. Collaboration, I think it's really important. Being able to listen carefully and understand the needs of your collaborators, and perhaps land with a deliverable that is different from where you started off with, but it's for the greater good, is really important. Patience is a given. Motivation, and I put it there more to think about people who are motivated by their own success and promotions can be very, very successful. But I think in terms of global oncology, motivated by improved patient care in a global setting, I think probably it's the more important priority to make things happen. In terms of deliverable skills, I think teaching, research, clinical, all of those are a given, but having the right mindset to modify how we teach in different environments, and bringing research skills, being able to ask a question, collect the right data, be it in a laboratory, in the field, I think is a critical skill. Leadership, at least not being able to, not being shy from it and want to learn and to change practices in different environments is important. Being able to speak language across disciplines and being able to organize ourselves. And then the organization piece linked into being passionate and compassionate to your patients, but more importantly to yourself, to make sure it's sustainable and avoid burnout, right? Prophylactically, very early on, is really important. And finally, the impact, I think I have mentioned that already, making a difference. Balancing act, how do we balance what the needs are of the passion of the individual versus the needs of the department? I would like to think about it more as an alignment. I think there will, I will submit that there's always a way that for something that you're passionate about, to be able to align with the goals of your department and be able to make a case and move forward. Stop there.
Thank you. Thanks, we'll move right to the next slide. I think this is Dr. Gopal's.
Mm-hmm.
Yep.
Sorry, are you trying to talk to me?
Yes.
Or?
There.
Sorry, I can't hear you when you're away from the mic. Is it my turn then, or?
Yes.
Okay. So hi everyone, thanks for having me. Sorry I couldn't be there in person. It's a little weird kind of hovering over the other panelists in the background. I was asked to prepare a slide, and I have one, but I'm not sure that it says very much that others haven't already said. So I'm happy to just kind of forego my slide and sort of leave additional time for the panel discussion. If that, I mean, that seems most sensible to me. I don't know what you were thinking.
Okay, we can, so for the sake of time, maybe we'll do Dr. Shah's, if Dr. Shah has some things to say, and then we can open it up for discussion.
Sure. Can I get my slide? But in the meantime, I can start. So first of all, it's a real privilege to be here. And you know, having done global oncology for almost 30 years of my life now, it was wonderful to hear the next generation of global oncologists talk. It puts me in a very strange place because I have a mentee here, Kristen Schroeder. She was a young medical student at Georgetown who was trying to find her way, and today she's one of the most successful global oncologists in pediatric oncology, blazing a new trail, as much as I know her. I also have here a daughter of my mentor, one of my mentors from the NIH, Rohini Bhatia, is a young medical student whose father mentored me when I was a fellow at the NCI. So my journey actually, I think I'll talk more about why I did global oncology and how I move global oncology ahead today for my residents and my medical students and for the faculty that work with me. So I wear a number of hats. Not only am I a professor of pediatric oncology at Georgetown, I'm also the head of the Children's Hospital at Sinai in Baltimore and chief of pediatric oncology there. So I look at it in two different ways. A few years ago, I also started my own nonprofit called the Aslan Project, which builds capacity in pediatric oncology in developing countries. And we've started the first program ever for cancer in Ethiopia and have been very successful, having worked there for about 6 years. So I was a young medical student. I saw a number of kids die. I'm originally from Pakistan. Pediatric cancer was not priority for us in those days. Kids were told, parents were told to go home, and they went home without any morphine, in terrible pain, which is why I'm a very big proponent for palliative care early on as well. I moved to England. There I used to spend my time in between my internships and residencies, going to the Royal Marsden Hospital, just trying to learn about pediatric cancer. Moved to the United States, worked at Penn State, but then had the opportunity to do my fellowship in pediatric oncology at the NCI. At the time when Phil Pizzo and David Poplack, who actually wrote the textbooks on pediatric oncology, were there. In my second year, when I started my fellowship training in research, I chose the lymphoma biology section. And I couldn't have made a better choice because Ian McGrath, for those of you who may not know him, is a legend in oncology and actually in pediatric lymphomas. He was my direct mentor. And Ian was just starting his trips to India and Pakistan and Nepal and the Middle East and South America, and I tagged along with him. And that's how I learned. And some of the protocols that we put together for pediatric leukemias and lymphomas are still being used in India today. Some of the work that he did in pathology in Africa is still being utilized today. So I learned through him what it meant to go to a lower middle income country and to look at the challenges that one faces over there and how do you overcome those challenges, but more importantly, how do you work with the people over there without making them feel like they don't know anything, like you've come there to impose your conditions, your rules, your way of life, your way of practicing medicine on them, and not reminding them each time that it's a privilege to be in their country. It's a privilege to work with them, and that each time I walked back and came back to the United States, I had learned much more. Who I am today is because of the experiences that I've had in different parts of the world. So as I moved on and came to Georgetown, I was very fortunate because we have a great interest in global health over there. And through that, I got the opportunity to work with numerous medical students who, through the connections that I had made with Ian, I was able to send to Africa. I was able to send to the Latin America. I was able to send to India and Nepal. And we sent them to oncology programs. Many, many of them have chosen to do global oncology today. And they went there and they worked hands-on with young mentors like Kristen and so many of you who are working in these countries right now. When I moved to the Children's Hospital at Sinai, there was a big buzz there. Everybody wanted to do global oncology. Somebody was running off to Haiti, somebody was going to El Salvador, somebody was going there, but there was no cohesion. And there was no real planning, and there was no real preparation. When you take a resident, or when you take a medical student, or when you take a fellow and send them to a low middle income country as a chair, as a chief, you are obligated to prepare them first. The American Academy of Pediatrics has just brought out a whole issue on how do you prepare pediatricians for global health, because it is so important. It's a right for us now to train pediatricians to do global health, because not only do you do it outside the country, you also do it within the country with the large immigrant populations that we have here today, because their problems are unique too. So what I've tried to put together is a Global Health Institute at Sinai right now, where we actually put our residents and the medical students who come with me through Georgetown, because I'm very actively involved and we have an endowment to do global health over there right now, through modules of training. We send them to immigrant clinics. We send them to immunization clinics. We talk to them about palliative care, and then we take them with us. And I was just talking to Kristen, because I think she's going to see a host of medical students come from Georgetown to her. And that is how you train. You start from the beginning and you take them through the various steps, and you teach them the respect that it takes to go to another country, what you can learn from there, not just what you can give to them. And 5 years ago, I had 2 kids come to me from Ethiopia. Both of them misdiagnosed, late presentations. They both did not do well. We gave them good quality of life, but we were unable to change their life path. So I was invited to Ethiopia. And when I went there, 8,000 children with pediatric cancers under the age of 21 are diagnosed there every single year. And when the first time I went to the Black Lion Hospital, which is the major teaching hospital in Addis Ababa, children with cancer were lying next to children with HIV, next to children with measles. There was no future for them. There was a 0% survival in that country. So after talking to the Ministry of Health, after talking to the hospital officials, it took back and forth several years for me, but we were successful. We've established the first 2 pediatric